Good afternoon, final years. Can you hear me?
Yes, ma'am.
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah. Everybody is come?
Yes, ma'am.
Ma'am, one girl is waiting, ma'am.
1 minute. Yeah. How many people in your batch?
Ma'am, 9, ma'am.
Okay. So 9 people are there, no?
One person is absent, ma'am. Gokul.
But already 9 okay, including me, 9 participants.
In youth 9.
Yeah, okay, fine. Yeah. So today's class will be dealing with multilocular radiolucencies. Okay, so today's class is that on multilocular radiolucencies. Now, in what you understand by the term multilocular? Now, when you say multilocular, it is nothing but there are multiple locules. If you could see in this picture, the soap bubble appearance, there is 1, 2, 3, 4, 5, 6 pictures, 6 locules. So they are called as multi-locules, that is small locules which coalesce together and form a radiographic image. That is called as multilocular. Why I am so much stressing this? There is a difference. Multilocular and there is multiple. So when you say multilocular, that is the locules, as you see here, the locules are all arranged in a one picture only, which is separated by a respective septase. Whereas when the term comes multiple radiolucencies, that is, there are different radiolucencies in the area, in a specific area, but they are not coalescing together. That means they are multiple radiolucencies which are there in the jaw, in the hand, in the head, but they are not formed together. Whereas multilocular is a one entity of radiolucency which has got multiple locules or multiple compartments. So these compartments are nothing but they are divided by different septae. Now, can you think of any example for multiple radiolucencies? Any example if you remember what you have read? Multiple.
Ma'am, OKC, ma'am.
Which one?
OKC, ma'am.
No, OKC is not multiple. Well, no, okay. Why do you say OKC is multiple?
Ma'am, because there are many radiolucencies seen in a radiograph, ma'am, wherever there's the cyst.
Correct. So, okay, that way you're trying to say. That means because OKC can be in different locations. Correct? That's what you're trying to say.
Yes, ma'am.
So, any lead on what syndrome it is associated with?
Ma'am,
Any syndromes which is associated with multiple OKCs? Any guesses? Anybody else? It's based on syndrome, right? Have you heard about it?
yes, ma'am.
Yeah, okay. So see, that is a multiple radiolucencies, that is a multiple OKCs which you can see. But they are another, this thing is within the radiolucency, your OKC can also be multilocular. So there are multiple radiolucencies, means there are many radiolucencies in the jaw, which is a OKC. But as such, per se, if you say there is a one lesion, which you see in the body and the ramus area, within the radiolucencies, there is multilocularity. So another example, anybody can guess of multiple radiolucencies? Any guesses? The first name is multiple only. Where do you see punched out lesions? Any guesses? No idea. Okay. So it is multiple myeloma, where you see typical punched out lesions on the skull area. That is different round areas you see in the skull. So this is a very typical example of multiple radiolucencies. So be clear what is multilocular, what is multiple. Multilocular is within one radiolucency. There are septae which are formed and they give the appearance of multilocular. That is, many locules are compartments are formed by the septae within a radiolucency. They are all merged together as a one entity. Whereas your multiple radiolucency is, there are different radiolucencies in an area which is not connected with each other. They are all different entities. That is multiple. That is many radiolucencies, what you're trying to say. So this is the difference, what you say between multilocular and multiple radiolucencies. Now your multilocular radiolucencies are produced by multiple adjacent, frequently coalescing and overlapping pathologic compartments. As I've already repeated, there are different compartments which is also called as a locules. These compartments are formed by the septae within a radiolucency is one thing. Next is they occur in the maxilla but are found more commonly in the mandible. They may occur in the maxilla but very commonly most of the lesions are found in the mandible. Next is unilateral lesions. So now when you say unilocular, so unilocular is nothing but a single radiolucency what you see there. Unilocular radiolucencies that is perforated the cortical plate may resemble those of multilocular entities. Now what happens is when there is a unilocular, when there is a lesion, it may appear as unilocular, that is one radiolucency. But because of the destruction or the perforation of the bones which is taking place or thinning of the bones which is taking place, that is where your septae are formed. And these septae will go into multilocularity. Okay, so these septae, so unilocular radiolucency may also look multilocular by the septae which are formed. So unilocular lesions that have perforated the cortical plate in one or more areas may cause radiographic images that resemble those from multilocular entities. Unilocular radiolucency, unilocular lesions that have perforated the cortical plate in one or more areas. Here in true multilocular lesions, there are chambers which are separated by septa of bone which are usually discernible on radiographic examination. That is what it means. Sometimes it is usually we don't see. If it is a thin septae, it is very difficult for us to assess or see the septae. Now here in this slide, you can see the different multilocular or the lesions which comes under the category of multilocular radiolucencies. But the very main important one are the eight ones. One is your OKC, amyloblastoma, your odontogenic myxoma, central giant cell granuloma, giant cell lesion of hyperparathyroidism, cherubism, aneurysmal bone cyst, and your vascular central hemangioma of the bone. So these are the main 8 things which will be expected in an answer when the question is multilocular radiolucencies affecting the jaw. And this multilocular radiolucencies affecting the jaw can be an expected 10 marks question for you also. Enumerate the multilocular lesions affecting the jaw. Write in detail of anything, maybe your OKC, your central hemangioma or anything. So this is a very commonly asked question in your written exams as well as in your viva. So when you say in your viva, your 8 lesions should just come sleep. That is what it is. Your odontogenic keratocyst, amyloblastoma, odontogenic myxoma, CGCG, giant cell lesion of hyperparathyroidism, cherubism, aneurysmal bone cyst, and central hemangioma. Okay. So these are the typical appearances of your multilocular radiolucencies. That is, these are the 3 different or very commonly seen appearances in a radiogram. First is a soap bubble. Now, if you see this picture, if you see these 3 pictures, the first one is a soap bubble, the second one is a honeycomb, third is a tennis racket. Now, when you say soap bubble, as you said, the locules are bigger in size, they are very well circumscribed or circular in shape, and they overlap over each other. Whereas honeycomb, as if you have seen a honeycomb, you would know the compartments are very small but uniform in size. Then it is a tennis racket. Now, as the name suggests, tennis racket, that is the septae which are formed are most of the time it is straight, it is in 90 degrees. So that is why you get locules which are square in nature or rectangular or triangle in nature. Whereas in your soap bubble and honeycomb, you get angular type of locules. That is, they are curvaceous, they are bent. Whereas in your tennis racket appearance, because of your locules or because of your septa, which are more determined towards adjusting at a 90 degree or perpendicular, the compartments tends to be more of triangular, rectangular or square. That is more of your geometrical designs which you see there. So this is the typical difference between soap bubble, honeycomb and tennis racket. And these three are the prominent your multilocular radiolucencies what you see in your jaw. That is most commonly found thing what you see in your jaw. There is something also called as a spider spook appearance. That is, it looks like a spider web. It looks like a spider web. That usually you can also see it in ameloblastoma also, which is also called as a spider spook appearance. Now when you come to anatomy, so before knowing what is the abnormal thing, what you see in multilocular radiolucencies, first thing you should know the normal anatomy in the maxilla or mandible, which you shouldn't get confused for any other pathology. That is, you should know the normal areas or the normal things in the perioral region instead of getting confused. So maxillary sinus usually has several compartments that project into the surrounding maxilla and zygoma, giving us a septae-like appearance. If you see these two pictures, see here, if you see this picture, you can see there is a line here. So they almost look like septae. And if you see here, there is a line here. It almost looks like locules, especially in case of your soap bubble. Because in your soap bubble, it has got round locules, which are 6 in number, 6 or 7 in number. So when you see the picture, you see if the locules are there. So it may give you an appearance of soap bubble appearance. So if you don't know the exact anatomy of the maxilla and mandible, exact anatomy, then it is very difficult for us to assess. Okay, then we will start thinking, okay, any pathology is there or anything different is there. But that's why you should know the anatomy. So this is this picture. Both the pictures will show you the basic anatomy of maxillary sinus in the edentulous area. So here also, if you see the locules like this, one is here like this, and one is straight above it is. So it is more of a locules which are arranged over each other, which overlap over each other. So this is the normal feature of a maxillary sinus. Next is the bone marrow spaces, which is the bone marrow spaces and the trabecular pattern. Here, if you see the second picture, one locule is here, one locule is here, there's another locule here. This locule has 2 sections. There is one more here, halfway. Okay, so these things and all also looks like multilocular radiolucencies only, because there are radiolucencies which are also attached to each other and they form a proper locule or form a proper compartment. So that is how it has to work. That is how it has to look. So you should never get confused between these normal pathologies, what you see there, and you think it is a normal anatomic variation, and you think it is a pathology here. Okay. Next, we will talk about, first thing we will talk about is odontogenic keratocyst. Now, it is a non-inflammatory odontogenic cyst which is coined by Philipson in 1956. It is usually seen in the second and third decade of life with the male and the female ratio of 3:1. See, here again, it is a painless swelling. The OKC, it can be associated with an unerupted tooth also. It is a painless swelling, and the main consent of this painless swelling is there is no buccolingual swelling. It is more of an anterior-posterior swelling. That is one of the characteristic feature of OKC. The characteristic feature of OKC, where it is a swelling which is usually seen in case of your in anterior-posterior direction than in comparison to the buccolingual direction. That is why what happens, because it is going anterior-posteriorly, there is no much of swelling in case of buccolingual direction. No swelling in case of buccolingual direction. Okay, so aspiration is thick yellow cheesy material. That is basically it is made up of keratin. That is why the aspirate of your OKC being a cyst also, it is not a thin aspirate what you see in case of your cyst, or what is you call it as a yellowish fluid what you think of. Here it is aspiration is thick because it is filled with the keratin in that. The most common location is the molar ramus region. The most common location, okay? Common location may be associated with the tooth or most likely. Now, if you see this picture, it is actually one radiolucency what you see here. Now, here there is a radiolucency, but within that, can you see this septase like this? All the septase. Here also, there are septase. Okay, here in this region, there is a septase. So that is another characteristic feature of OKC is scalloping of the borders. So this scalloping of the borders you very typically see in case of OKC. That is scalloping of the borders what you can think of. Now, what are the typical features? What are the typical features of your OKC? Okay, so basically this OKC will fill the ramus area, fill the whole ramus area. The margins can be sclerotic with scallop outline, especially C. Now, this area what you call it as the margins. Can you see this? These are the margins. That is where your lesion will be present, or till what borders the lesion will be present. And within that you have the scalloping what you see here. The margins are till here where the border ends, and then you have this is called as a scalloping. And in certain areas the perforation also can be seen. It is sometimes unicystic also, which has a scalloped borders, occurs with multilocular appearances. It doesn't have a major age prevalence is there, but not very commonly followed age prevalence is there. Occasionally the cyst expands the cortical plates and perforates. It develops a firmer to fluctuant swelling what is there, which is filled with keratin, because it is a OKC, that is odontogenic keratocyst. Odontogenic keratocyst. Now, as the name suggests, kerato, that is, there is a presence of keratin in that. So when there is a presence of keratin, it can't be the typical fluctuant as you see in cyst, right? Which is basically a water-filled area there. So when you press, it is fluctuant, but here it is keratin. It's more thicker in nature. So more thicker, so you will have a consistency of firmer in consistency in comparison, and the lumen of OKC is filled with keratin, which is also there. So when you aspirate it, you get a cheesy yellow material, and when you aspirate, you should use a large bore of needle, not the usual insulin syringe what we use. You should use a large bore of needle when you aspirate in case of OKC, because of the presence of keratin. The inside content will be very thick. So that is one of the criteria what you should keep in mind while aspirate. So the aspirate is a cheesy yellow color what you see from there. The other thing is, after treatment, the recurrence rate of OKC is very good. In a sense, recurrence rate is very good in the sense there is a lot of recurrence which is being stored in the age range of 3 to 4 years of follow-up. So there is recurrence is very commonly seen. Another characteristic feature of your OKC is there are two types in that. That is again based on your histopathological classification. That is, one is the parakeratinized type, one is the orthokeratinized types. Okay. Now parakeratinized type is aggressive, whereas orthokeratinized type is similar in behavior to the other jaw cysts. Parakeratinized type is aggressive, whereas orthokeratinized type is more of a cystic in nature. So parakeratinized and orthokeratinized, again based on their histopathology, we will be able to tell which is a parakeratinizing orthokeratin. Because the why this comes into criteria is the orthokeratinizing mucosa will have a similar feature as a cyst, whereas the parakeratinizing type will have more feature towards the parakeratinized is more aggressive in nature and more of a tumor-like associated mass. Here what you see there. Here the wall is thin, the basal layers are usually cuboidal and arranged in a palisading row. Then afterwards, the stratum cornea may be typical in appearance with keratinized cells and nuclei, what you see there. Now the right described orthokeratinized variant of odontogenic cyst. Now on microscopic examination, what happens is the basal cells are usually flattened and cuboidal. That is orthokeratinized. Orthokeratinized means cyst type of OKC. Parakeratinized, more aggressive tumor type OKC, what we saw, what we heard of. Okay, so now when you say orthokeratinized variant, the basal cells and the cuboidal cells are usually flattened and bright in nature, are usually cuboidal, described that appears as a single cyst. A single cyst has a predilection for male patient, It is most common in the second and the fifth decade, appears most often as a dentigerous cyst in the posterior mandible and shows little aggressiveness and clinical examination. Appears as a single cyst, has a predilection for male patients, is most common in the second and the fifth decade, appears most often as a dentigerous cyst in the posterior mandible and shows little aggressiveness or clinical behavior. So these are the different characteristics what you see. Next, as it's there, the lumen may be cloudy because of the presence of keratin. So that is why this is called as a Milky Way lumen. The lumen in the OKC is also called as a Milky Way lumen. Milky Way lumen. So that is why it is called. Next is, although developing teeth may be displaced, OKC usually does not. This is another characteristic feature of OKC. Resorption of the teeth or the root is not seen. Max, you can only see the displacement of the tooth. Then when OKC is seen bilaterally in a patient younger than 10 years of age, it is called as a Golling-Box syndrome. So there are two syndromes which are associated with OKC. One is the basal nevus syndrome, which is associated with multiple OKCs in the jaw. Multiple. So there are basal nevus and Golling-Box syndrome. Next is the periphery and the shape. See, OKC shows a usual evidence of cortical border. If you can see this area. This is the cortical border. They may have round or oval shape, what you see. It can be associated with the erupting teeth also. The cyst may have a smooth, round or oval shape with a scallop outline. And mostly it is radiolucent. Only thing is presence of the presence of keratin within the lesion. Presence of the keratin within the lesions may give a dense opaque-like appearance. Because of the presence of keratins which are there. And in some cases you have curved internal septae may be present, giving a lesion a multilocular appearances. So in some cases curved present may be present, giving the lesion a multilocular appearances. Now, effect on surrounding structure. First, very important key feature is minimal expansion, because most of the expansion is anterior-posterior direction. So when there is an anterior-posterior expansion, it is very difficult for us to assess. If it is a buccolingual expansion, within a few, once the changes are there, once the swelling appears, we will immediately get to know. Expansion occurs throughout the mandible except the upper ramus and the coronoid process. Expansion occurs throughout the mandible except the upper ramus and coronoid process. Inferior alveolar nerve canal may be displaced inferiorly. In the maxilla, the cyst may invaginate and occupy the entire maxillary antrum. The inferior alveolar nerve canal may be displaced inferiorly. In the maxilla, the cyst may invaginate and occupy the entire maxillary antrum. Differential diagnosis is dentigerous cyst, amyloblastoma, odontogenic myxoma, and simple bone cyst. Now, dentigerous cyst, if there is an aspirate, looking at the aspirate, you can decide that it is not a OKC. Amyloblastoma, again, picture is not convincing again. Next is a botroid odontogenic cyst. This is the type of a cyst, or here if you see here, one locule, another locule here. So they are forming together, which looks like a bunch of grapes. Okay, which looks like a bunch of grapes. And these are the botroid cysts, odontogenic cysts. They say that they appear from the lateral periodontal cyst. So here, odontogenic cyst was first reported by Weathers and Waldron in 1973. It's a multicystic variant of lateral periodontal cyst. Recurs approximately 8 to 10 years after surgery. So it is a typical appearance of grape-like appearance was seen here. Multicystic variant of lateral developmental periodontal cyst and also recurs. Age is 50 years. Males, swelling or expansion which may be tender or associated with drainage, and it is asymptomatic. So usually more commonly seen in the mandible area, especially in the premolar and the lateral incisor area. Occasionally it appears in maxilla, especially between the lateral incisors and cuspids. Then average size is 1.6 centimeters, and size eventually correlate with the propensity with recurrence. Differential diagnosis is OKC, mental foramen, neurofibroma, radicular cyst at the foramen of the lateral pulp canal, and multiple cysts with multilocular appearances. So these are the differential diagnosis for your botroid odontogenic cyst, which is also called, which appears like a bunch of grapes. Next is amyloblastoma. Amyloblastoma was recognized by Cusack in 1827. It is a tumor which arises from the odontogenic epithelium. It is persistent and locally invasive, aggressive but benign growth characteristics. It arises from the dental lamina and dental organ, divided into solid, multicystic or unicystic. Unicystic develop as a single entity, may form from the epithelial lining of the dentigerous cyst called the mural amyloblastoma. So unicystic develop as a single entity, may form from the epithelial lining of the dentigerous cyst, which is called as a mural amyloblastoma. So amyloblastoma, which derives from the epithelial lining of the dentigerous cyst, is called as mural amyloblastoma. Slight predilection for men, that is age 20 to 50 years, grow slowly, no symptoms occur in early stage, gradual increase in size, facial asymmetry is reported, okay, and usually the age is 20 to 50 years. The teeth involved may displace and become mobile, and also they may elicit a bony hard sensation or a bony hard on tumor enlarged. And if the lesion destroys the overlying bone, the swelling will feel firm and fluctuant. Molar ramus region is a very common. Maxillary, commonly third molar area, but very rarely you see in the maxilla. Now in the mandible, it is seen because another thing is your mandibular bone is more dense. Okay, whereas your maxillary bone is more porous in nature. What happens? The spread of the lesion is more easier in maxilla than in mandible, because your maxillary sinus is nearby, your nasal cavity is nearby, and the bone which is surrounding the area is thin and it is porous in nature, so the spread is very fast. So that is what is a so then afterwards it occurs usually in the third molar areas, you see that. If you see this picture, you can see multiple locules. One, there's one more here, two, there is three, and there is four, and one more, five. So there are 5 locules which are present in case of this picture. Okay, so the periphery is usually well-defined periphery. You can see curved or small lesions in the border. Okay, and peripheral lesions maxilla usually more ill-defined. That is because your maxilla has many structures within the jaw there. It goes on destructing areas, so you may find the borders more ill-defined. Whereas your mandible is a thick, dense bone which localizes the tumor mass to a specific region. So these are the different appearances of your ameloblastoma, what you see here. The first picture, if you can see here, there is locule within the locule. There are so many locules which are seen there. So radiolucent 2 mixed with the presence of bony septa creating internal compartments. These septae are usually coarse and curved. If you see here, can you see this septa here? It is coarse and curved. If the septae are not curved, you cannot find such locules at all. Because they are curved and this thing coarse, you can find. So this is a typical appearance of your soap bubble appearance. If you see this, because the locules are bigger in size, they are well arranged. So that is why they coalesce with each other. So they appear as a soap bubble appearance. But if you see this picture, it looks more of a honeycomb, because the locules are very small in size, and they're arranged one over the other. Okay, the septae are giving the curvaceous appearance or a coarse appearances. So in ameloblastoma, you can see both the features, that is your honeycomb and soap bubble pattern. Next, loculations are large in the posterior mandible and smaller in the anterior mandible. Loculations are large in the posterior mandible and smaller in the anterior mandible. Extensive root resorption, that's the typical appearance what you see in ameloblastoma is knife edge pattern. So there is tooth displacement also is seen, expansion is also seen, which also gives you an eggshell crackling like appearance. Actual perforation of the bone is a late feature of ameloblastoma. Differential diagnosis, dentigerous cyst, OKC, CGCG, odontogenic myxoma. Dentigerous cyst, as the name suggests, associated with the erupted tooth, but the aspirate is positive. That is, you may get a straw-colored fluid in case of your dentigerous cyst. OKC, the typical feature is there's no swelling buccolingually, only AP, anterior-posterior. You can see the expansion of the lesion, whereas ameloblastoma, you have a huge swelling what can develop at the posterior aspect of the mandible. Then another CGCG, that is a central giant cell granuloma. The characteristic feature is usually in central giant cell granuloma, the lesion appears anterior to the premolar area. That is a very characteristic feature of your central giant cell granuloma. That is, it appears anterior to your premolar area. Odontogenic myxoma, again, it is a tumor which is associated with the mesenchymal cells. There also the typical radiolucent appearance, multilocular appearance, what you see is a tennis racket appearance. That is, the locules are all arranged in a septa, which are arranged at a 90 degrees or right angle to each other. That is why the locules which are formed is more of a square, rectangular or a triangular area what you see there. Now based on your microscopic appearances, see what happens in ameloblastoma is there's a bone resorption which is taking place. Now this bone resorption which usually takes place is because of interleukin alpha 1 and interleukin 6, that is which is present in the stellate reticulum like cells. These are the things which helps in the resorption of the bone what you see there. Okay, so that is where the resorption is noted in case of your ameloblastoma. Then microscopically it is divided into follicular, flexiform, your acanthomatous, desmoplastic and granular cell, out of which the desmoplastic one is a very incomparisonly which we can also frequently see desmoplastic ameloblastoma, which usually occurs in the anterior mandible. Anterior mandible is the main predilection of site what you see there. Okay, so okay, so that is, these are the different types of your ameloblastoma what you see. Now this is the world's classic description of ameloblastoma applicable to mandibular lesions. World's classic description. This is the classic description of ameloblastoma. First radiological finding is resembles a dentigerous cyst without septae within a lesion. So dentigerous cyst, if you can imagine, it is a cyst associated with the unerupted tooth. So it is a well-defined radiolucency what you see there without septa, more commonly seen in the ramus area. Only suspicion increases to ameloblastoma is if the patient is about 30 years of age. That is a main suspicion or differentiating factor between dentigerous